In this module, we will discuss flaps and flap design used in periodontal surgery. The surgical flap is defined as the separation of a section of tissue from the surrounding tissues, except at its base. Although we will introduce many terms in this module, let's start by first defining two terms, a primary flap and a secondary flap. I'm going to begin with the secondary flap because that is the coronal tissue that is removed during a procedure. The primary flap is the portion of the tissue which remains after removal of the secondary flap. This may sound confusing, but let's look at a clinical slide to highlight these differences. In this case, where a scalloped internal bevel incision is being done, you can see that there is a distinct incision line. This tissue, which will be removed, which is coronal to the underlying tissue, is the secondary flap. Again, the primary flap is that tissue which remains. Now, anytime when we're considering our flap design, we have to take into account multiple factors. First, we need to think of anatomy in the area. Is there any potential blood vessels, any potential nerves that we could potentially harm by our flap design? Second, we need to think about blood supply and how to maximize that to the flap. And we're going to look at that in a following slide. Third, we look at tissue morphology. Does this tissue need to be thinned, or is it of adequate thickness as it stands? Next, we have to determine how we can best access the bone if our procedure requires that. Our fifth factor to take into consideration is the degree of flap mobility required. We have to ask ourselves, do we need to cover some tissue in order to assure success? For example, are we doing a bone graft where we want to have good closure over it with primary coverage, or if we're doing a mucogingival procedure? And last, we have to determine, as part of that decision-making process, the final flap position. One key element of flap design is based on the principle of maintaining an optimal blood supply to the tissue at all times. Any alterations in gingival circulation that resulting from various periodontal flap design can have a distinct outcome on your result. Multiple studies have looked at humans and by means of fluorescein angiography have determined the optimal flap height to base ratio. In this diagram, this is our base, and all of our blood circulation comes from this base to support the flap. There's certainly some anastomosis that takes place from the opposite side at the crest, but again, the majority of our circulation comes from the base. If we exceed a flap height to flap base ratio of 2:1, we will have compromised this overall blood supply to the flap. So again, the important takeaway point here is that your base to your height ratio should never exceed one in which the height is 2 times greater than the base. Now let's look at some terms that define what we really do. First, let's define the term full thickness flap. This is a flap that includes epithelium, connective tissue, and periosteum. It is the most common type of flap used when access to the bone is indicated for resective or regenerative procedures. In this diagram, you can see an internal bevel incision is done, and upon reflection, the epithelium, the connective tissue, and the periosteum is reflected away from the bone. Clinically, it appears like this. Here you can see where a sulcular incision was done on the facial, a full thickness flap was reflected, thereby exposing the alveolar bone. Now, a full thickness flap has many advantages. First off, it gives you increased visibility to the underlying structures. It provides you great access to the alveolar bone and also makes this an easier, quicker procedure to do. Disadvantages occur if you're in an area where you might potentially run into a root dehiscence or a root fenestration. Also, through human wound healing studies, we know that approximately about 3/10 to 4/10 more of a millimeter of bone is lost whenever we reflect a full thickness flap. In contrast, we have the split thickness flap. When the periosteum is not included in the flap, this is when you have a split thickness flap. This type of flap is used extensively in mucogingival surgery to leave an underlying blood supply where soft tissue grafting is performed to correct deformities in the morphology, position, or amount of gingiva. Again, looking at it on the diagram, you can see an internal bevel incision is performed, and this time, instead of going all the way to bone, there is a split thickness. The epithelium and the underlying connective tissue are reflected, leaving the underlying periosteum intact. Clinically, it appears as you see here. Again, we frequently do these for mucogingival procedures in combination with a full thickness flap. In this instance, a full thickness flap has been reflected coronally. Then, as we approach the mucogingival junction, a split thickness flap is done. This allows you to coronally advance this flap with minimal tension. Advantages of a split thickness flap are that by leaving the periosteum intact, you don't expose those root dehiscences or fenestrations. Also, we may have reduced alveolar bone loss on healing. The disadvantages are that you have to really pick your cases because if the tissue is thin, you run the risk of perforating the tissue if you attempt this type of flap design. It is also more technically demanding and time-consuming. Now, even though microsurgery has a place in periodontics, we need to discuss adequate flap design in terms of extensiveness. If you are too conservative in your flap design, you have the risk of increased surgical trauma as a result of the reflection. Your visibility is very compromised. It may lead to potential inadequate debridement. You, as the treating dentist, may become frustrated because you can't access the area, and you might end up with a poor surgical result. Now, we're at a point where we've completed whatever we needed to do to the underlying bone, and now it comes time to place the flap back up against the teeth and begin our suturing. Prior to surgery, we need to determine whether we're going to replace this flap in its original position, if we're going to apically position our flap, or if we need to coronally position our flap. Again, the final flap location is usually determined by the goal of therapy and the specific periodontal surgical technique performed. Let's review each one of these terms. A replaced flap is designed to be returned to its original position. It is used most often when surgical access for debridement of the roots is the primary goal, as in flap curettage or the modified Widman flap procedure. A replaced flap also is frequently used in periodontal regeneration procedures where primary closure over a bone graft, with or without a membrane, is of utmost importance. In contrast, an apically positioned flap is one that is apically displaced from its original position to either the level of the alveolar crest or about 1 millimeter coronal to the crest. This type of flap positioning is chosen when performing pocket elimination procedures, which may or may not involve the removal of bone. Finally, the coronally positioned flap is advanced coronal to its original position. The technique is typically used when performing mucogingival surgery, such as you see here around the lateral incisor, and is used to advance to cover either an exposed root, a connective tissue graft that may have been placed underneath, or a barrier membrane. To achieve passive positioning of the coronally advanced flap before suturing, the underlying periosteum is released with a sharp scalpel blade. Remember, in one of our previous modules, we discussed this as a periosteal releasing incision. This concludes our module on flaps and flap design.